Psychiatry, pathology, eating disorders. All right, so eating disorders, the first thing you're going to have to take away from a standpoint of questions is that it's going to be most commonly in young females. So that's going to be kind of your first hint that a question is going to be asking about an eating disorder. There's going to be multiple that they're going to be asking about, and I'll give you kind of a hard, fast rule for differentiating anorexia versus bulimia. All right, so first off, let's start with anorexia. Anorexia is going to be the intense fear of weight gain, okay? And that fear is going to lead to caloric restriction and severe weight loss. The patient is going to have a BMI that's less than 18.5, and that's key. That is the highest yield thing in the world for anorexia nervosa. BMI is less than 18.5, okay? Now, the patient is going to present with a lot of physiological disturbances. So they can have bradycardia, hypotension, hypothermia, hypothyroidism, osteoporosis. Some key things that you're going to notice are lanugo, which is soft, fine hair growth. So they could say soft, fine hairs are noted. And they can have amenorrhea, right, because of the disturbance in the GnRH pathway, right? That pulsatility is going to lead to decrease in pulsatility in GnRH and overall decrease in LH and FSH, and then finally a decrease in estrogen, which can lead to amenorrhea. All right, so remember that lanugo is going to be soft, fine hair growth, which is seen in anorexia, and they have a BMI less than 18.5. Very important. Okay, now something that's associated with anorexia nervosa, not highly associated, but it's associated with patients when you feed them again after anorexia. Okay, so a patient that struggles with anorexia for quite a while and they're severely malnourished, and then you go and you refeed them, you could have refeeding syndrome can occur. And what you need to know about refeeding syndrome is that when you give them a sudden increase in caloric intake, there's going to be a large spike in insulin that they've never seen before. And that leads to a drop in their potassium and a drop in their phosphorus, okay, and their phosphate. So if you see hypokalemia, hypophosphatemia, that's going to be one of your key signs for refeeding syndrome. If all else is normal and you have a drop in potassium and a drop in phosphate, you know that you're dealing with refeeding syndrome. And if it's someone that's, hasn't had a large caloric intake for quite a while, and then you give them some type of calories, that's going to be in the back of your mind for your number one differential. Okay. Very important. It's scary because remember, a decrease in potassium or phosphate can lead to cardiac complications and seizures. Okay. So we have to be worried about this. All right. So once again, anorexia nervosa is going to be the BMI less than 18.5, and they're going to present with lanugo, which is the soft, fine hair growth, potential amenorrhea. And then if you give them food again, it's going to lead to hypophosphatemia and hypokalemia. All right. Next is going to be bulimia nervosa. Bulimia nervosa is going to be recurring episodes of binge eating with compensatory purging. So if there's no compensatory purging, then that is something that you have to take into account, that it not being bulimia. Bulimia is very important with it having a compensatory purging behavior. Okay, so what does that mean? So if a patient has these, bulimia nervosa is going to entail someone that goes in and they have like just recurring episodes of binge eating. Okay, so they eat like 2 large pizzas in one sitting and drink 2 liters of Coke. And then after that, they feel remorseful about it, so then they're going to go and have some type of compensatory purging exercise, whether that might be puking, vomiting, or whether that might be running on a treadmill, okay? Some type of compensatory reaction to try to lose that weight quickly. So vomiting is kind of the most common presentation, but you could also see, running on the treadmill, going to the gym, running like 5 miles right after you ate all that food. Okay, that could be a compensatory reaction. Now, the key thing here is that the BMI is normal in bulimia nervosa. So anorexia nervosa, you have a BMI less than 18.5, and there's a type of binge eating purging type of bulimia or of anorexia nervosa that looks similar to bulimia nervosa, where the patient can, binge and then purge. But the key difference there with that type and the actual bulimia nervosa is the BMI. If the BMI is less than 18.5, your answer is going to be anorexia nervosa. Okay, majority of the time, like 99% of the time. If you have a normal BMI and they're experiencing these symptoms of purging as well as, binging and purging, that's going to be bulimia nervosa with the normal BMI. Okay, now, some key things that you have to look out for bulimia nervosa. The patient is going to present with associated parotid gland hypertrophy. That's one thing they might ask. The reason behind that is because you're going to have a lot of the times when you're purging, you could be vomiting, okay? And so that's going to cause a hypertrophy of the parotid glands, okay, right? Next, you're also going to see in bulimia nervosa a potential enamel erosion. From all that vomiting, you're going to see enamel erosion from the acid coming up from the stomach and passing by the teeth. You can see Mallory-Weiss syndrome, which we'll discuss in GI, which is just essentially like kind of like a laceration within your esophagus because you're just constantly puking, but it's not like a full-blown laceration. It's just like in the mucosa. It's like a scratch of the esophagus. You could see potential dorsal hand calluses. So from somebody putting their hands in their mouth, the back or the dorsal part of their hand is going to scratch on their upper teeth. And so that is going to be associated with bulimia nervosa. Okay? So scarring of like the knuckles essentially to induce their vomiting. And they can have a lot of electrolyte disturbances like hypokalemia and hypochloremia. All right? So once again, hypokalemia with normal BMI in a healthy patient, it's always probably going to be bulimia nervosa. I say it's always bulimia, but I'm sure there's some type of pathology out there that's going to have hypokalemia with normal BMI in a healthy patient. But I mean, yeah, obviously there is. But if you see like a hypokalemic patient with normal BMI and they're otherwise healthy and they say that there's, they could potentially be dealing with some eating disorder, it's always going to be bulimia. They could present with parotid swelling, erosion of the enamel, and scarring of the knuckles. Okay. Now, last thing. Bulimia has binge eating with compensatory behaviors. Do not forget the compensatory behaviors because you can associate that with binge eating disorders, because binge eating disorders is the next eating disorder, which is recurrent episodes of binge eating without the purging. Okay. So they don't have purging. They will just sit down and they'll eat two large boxes of pizza and then just be like, okay, like I'm done. And then it will be like once weekly. It doesn't happen all the time, but it'll just be like once weekly where they're just like binge, okay? And so there's no inappropriate compensatory behavior after that. So no purging associated with binge eating disorder compared to bulimia nervosa, all right? So those are our kind of key eating disorders. Anorexia nervosa, the key takeaway here is that the patient is going to have less than 18.5 BMI. Bulimia nervosa, I don't know if I messed up. Anorexia nervosa is BMI less than 18.5. Bulimia nervosa has normal BMI with compensatory purging. And then binge eating disorder has no inappropriate compensatory purging, but it's followed by binge eating. All right. So that's our eating disorders. There's a couple other things I wanted to just touch on. We have gender dysphoria. Gender dysphoria is just strong and persistent desire to be another gender. Okay. So these are patients that, they have dysphoria when thinking about their gender. So that is going to kind of relate to you in a question as someone who has this strong desire to be another gender. Okay, so that is going to be a question that you might encounter. And then lastly, for body dysmorphic disorders, once again, for any body dysmorphic disorder, you're going to have a fixation on a perceived defect in appearance. Okay, so these patients are going to be sitting in front of a mirror for quite a while, looking at themselves, continuously, like grabbing their thighs or grabbing their belly and looking at themselves in the mirror with repetitive behaviors in response to that fixation. So that repetitive behavior would be like looking at themselves in the mirror over and over and over again over this perceived defect. Okay, now, majority of the time, these patients are going to be normal BMI. They're not going to be really dealing with anything of like severe obesity. They're not going to give you a patient that has BMI of 40 that's constantly checking themselves out in the mirror and saying that they feel uncomfortable in their skin and that they want to lose weight. No, these patients are going to be normal BMI weight. Okay. And that's how the patient's going to present in the question stem for this body dysmorphic disorder. Okay, so they're going to fixate on a perceived defect to themselves that others do not notice. Okay, so they have the normal BMI, okay? And so then that's very key to kind of making the differentiation. And then lastly, the last thing I want to talk about for this chapter is going to be sexual dysfunction. Sexual dysfunction is very, very common in psychiatry where they talk about and they question a lot about it. The key thing that you need to take away is that if a patient, usually male patients is what the question stem is going to be about, if the male patient fails to have an erection and they come to you and they ask you about this inability to have an erection, the number one question you're going to ask them is that, do you get erections at nighttime, okay, or in the morning? Because if they have erections at night or in the morning, then it's some type of psychological issue. They might be nervous in their sexual relationship, leading to a erectile dysfunction, okay? So it's not going to be some type of like pathological issue involving the genital system. It's just going to be a psychological issue. Okay, so that's the key thing that you have to ask the patient. Do you have an erection at nighttime? And if so, it's not going to be something very worrisome that's involving the actual anatomy of the genital urinary system. It's going to be probably an issue with psychiatry. Okay, so that's a key takeaway for any type of sexual dysfunction. Other than that, that's going to pretty much cover all of our eating disorders, our gender dysphoria, and our sexual dysfunction.